among the lowest in the world here in Sierra Leone. Evidences show that there is a huge burden of premature deaths, and official estimates were high, with very high under 5 mortality rate, which is 122, and high maternal mortality rate, which was more than 1100. But these estimates were mostly model-based, and we think they do not reflect the reality on the ground. And Stat Sierra Leone and others mandated institutions here, they only report less than a quarter of deaths annually, and without even causes of death. Plus, here, most people, they die in home without medical attention, with no documentation, and these were issues too, to know what's happening in terms of mortality and to know why people are dying. Next. Okay, so that's why we built this sample registration system, which is an initiative supported by Gates Foundation. It's a nationally representative system. We cover around 5% of the population, which is around 300K people are enrolled in our system. We go to every district and every sampling frame. Our sampling frame is based on Sierra Leone sampling frame, and we selected them from that sampling areas. The methodology is built on top of 3 core modules. The first one is enumeration, where our surveyors go to our the enumeration areas and enroll people, try to identify if there is days. If there is a days, they do verbal autopsy, electronic verbal autopsy, and they synchronize it to the cloud. And we do also quality checks through random resampling. To date, we are on the 6th round. Till the end of round 5, basically, we enrolled over 30,000 cases across Sierra Leone. Next. Okay, next, please. Yeah. So this map shows coverage of our work. As you can see, the purple dots actually shows the sampling areas where our team goes to conduct verbal autopsy, and as you can see, it's nationally representative, and we reach everywhere from Freetown to the southeast and west of Sierra Leone. Next, please. So, why is it coming again? Is it? Sorry, Miriam, this is.
Should I go to the next slide?
Yeah, but this is a repeated slide. I don't know.
Okay.
Okay, so the procedure, when a death is recorded by our field staff, we already have around 670 sampling frames across Sierra Leone. When a death is recorded by a field staff, she or he needs to conduct verbal autopsy, which is uploaded daily to the central server. That record is then assigned to 2 of our trained physician coders. They assign their own causes of death. If they agree, that will be the final cause of death. If they disagree, it goes to anonymous reconciliation. That means one of the physician coders agrees with the cause assigned by the other. If they still disagree, then a more experienced physician will assign the final ICD-10 cause of death. We call that step adjudication. Next. Okay, system is 100% electronic, and as a result, records can be coded in less than a week. So field staff goes, conducts verbal autopsy, they synchronize to the cloud. Then between the time of synchronization and coding, it usually is 1 week. Within 1 week, a final cause of death can be assigned to a cause. We work hard to ensure quality through rigorous transparent recruitment, regular GPS checks, narrative reviews. Regularly, narratives are reviewed and feedbacks are provided to field staff. There is audio recording, which are used during narrative reviews again. Supervisors do on-spot field checks unannounced, basically. Also, our physician coding, we used to do physician coding purely by physicians, but now we added AI tools, GPT-4, Interview, and in Silico V. They are there to support the physicians, to provide additional insights, not to replace the physicians, but we introduced this starting from round 4 of HealSL. Next, please. We monitor quality using personalized dashboards. This is a general view. We can see, this is from round 6, for example. We are conducting round 6 of our survey. We can see live the data coming. If there are low quality narratives, as you can see down, we have reviewers plus physician coders also see, and if there are issues, they flag the narratives. Now we can see this, the coordinators, the supervisors, everyone. But then surveyors, they have their own personalized dashboards. If they have a flagged low quality narrative, it goes personally to them. They check the narrative and they call one of the physician coders or the coordinators and try to understand what's wrong with that narrative and learn and try to improve in the future. So we use data monitoring dashboards. Next, please. So actually, our mandate, basically, we are funded to collect data and generate annual report on mortality and causes of death. And we share that to the Ministry of Health and Sanitation, other stakeholders, conduct this will be discussed with DMOs, district medical officers, and other stakeholders. But also we share a comprehensive report to the Ministry of Education, the Ministry of Health and Sanitation. We believe that this map allows the ministry and others to see where their programs are, whether they are working, and where the gaps are being observed. Next. For example, some of our outputs, if you remember, we just said that maternal mortality was high initially before we start conducting this SRS effort. It was around 1100, which is a model-based. But then after 2 round cycles, we did a general analysis, and it was actually 510. Now, this is not a small number. This represents around 1,300 days, maternal days. But it was half of the official report. And as a result, the WHO, they revised their model-based output. And I think that they changed it into around 400. But through continuous monitoring also, because we are doing this regularly every year. Now, as I mentioned, we are going to the same areas. And as I mentioned, we are on round 6 now. We observed that there is a reduction which is 318 by 2023, where we generated a maternal mortality report and submitted to the ministry. Also, there is a paper published based on that data. For example, this gives clear information for the ministry. For example, 25% of the time, it's hemorrhage that kills mothers. And there are so many other insights in the reports which actually help the ministry and gives the ministry important insights for data-driven targets. Next, please. The next one is on malaria. We have done a lot on malaria. We all know it's a general fact that malaria was a killer of children, and our data also confirmed that around 47% of all diseases in children under 5 was due to malaria. But then we looked at older children, 5 to 14 years old, and malaria is still a killer. It accounts for 39% of the disease. Now, I remember this when we present our findings after round 2. This came as a big surprise. We looked at young adults and adults 30 to 69 years old. Initially, we were conducting verbal autopsy for diseases below 70, because that's what we assume that premature mortality, okay? So for young adults and adults from 30 to 69 years old, malaria was still a leading cause of death. This ignites a huge debate, I remember, during that time, because everyone thinks that malaria doesn't kill adults, it kills only children. So we confirmed that it's a lifelong trait. This fundamentally changes how we monitor and evaluate our malaria control program. We are also working with the malaria control program. Next slide. I think on the next slide, you can see the malaria distribution by age, and these are heat maps, and by sex. The maps show malaria diseases by 6 higher diseases, malaria diseases for male, and also give different information for age distribution. So it shows the burden where actually the malaria is causing more diseases in Sierra Leone. Next, please. So it's not just for infections, but our data also brought some hidden endemics into focus. For example, road traffic accidents. We found RTS to be one of the top killers of young adults, contributing for around 7% of all deaths in that age group. And because our data has GPS coordinates is special, we also can map these hotspots for the authorities, where exactly those are common. We'll see on the next slide the heat maps. We also provided specific data for intervention. For example, our verbal autopsy showed that 51% of fatal RTAs involved motorbike. Motorbike is common here, but so they contribute for most of the RTA fatalities. This gives the Ministry of Transport a crystal clear target for safety and intervention. During our dissemination meeting, we invite representatives from every sector. One of the invitees are from the Ministry of Transport and Sanitation, the Ministry of Transport. They get reporters, they participate in the dissemination meeting discussions. Next, please. So So here you see three heat maps showing distribution of diseases in the country due to three causes of death. You can see here that dairy contributes a huge amount for children younger than 15 years of age. Road traffic accidents, as you can see, the distribution indicated on the heat map. Also, we learned that stroke contributes a lot for adult mortality, which motivated other researchers, we'll see later, to do more regarding stroke in Sierra Leone. Next, please. Uh, the verbal autopsy instrument has some questions regarding quality of care, and we used those questions to do some analysis on the quality of care. For example, for mothers who died, 24% of percent were over 2 hours from the facility. For stroke and RTA victims, it was 13 to 15%. They were away, like 2 hours away from the facility. We found out that care is also not affordable, provided that people here are low income. For example, if you can see the slide, the cost of treatment forced some families to skip other essential payments. You see the numbers. For example, 25% of stroke diseases, 21% of adult malaria, 19% of maternal, and 14% of RTA. Respondents said that the pressure, the financial pressure was too much. So even for those who went to health facilities like hospitals, 8% of them, they were not satisfied with the service. They didn't get the service they expected, for 8% for RTA and 7% for malaria. This somehow shows what exactly shows how and where exactly health systems are uh, failing, basically. Next slide, please. Okay, so when we found out that malaria is a number one killer in adults, because it also sparked lots of debates during our discussions, we tried to conduct a study, a validation study at Bo Government Hospital. This was funded by from other sources. Uh, and we presented our findings to the hospital staff, and we have a published paper, which I can share the link. The other thing is also this malaria issue sparked other initiative. We are now working to do a vaccine trial. We will be doing a safety trial on 300 participants. Then we'll do a larger scale trial on adult malaria, because child malaria vaccine has been approved, and it's already being administered in Africa. We are also now using this data to do some study on the impact of funding cut on the malaria control program, the recent funding cut. How is it affecting health facilities, and how is it affecting mortality? We just started that 2 or 3 months ago. I hope we'll see results after a year or so, because the impact would come slower. Following also our data, regarding stroke, one researcher used our findings to show that hospital-only data was severely underestimating the problem of stroke because it missed everyone who dies quickly or dies at home, which also shows that our population-based data proved that relying on facility data is flawed. This is also published recently. Next slide, please. To conclude, Helicel's SRS now form Sierra Leone's foundation for evidence-based monitoring. It supports data-driven decision at all levels. We give feedback to community, district, and national, to the ministry including. We have conducted conferences, one international conference so far, the Africa Mortality Symposium, and we are looking for funding for the next, the second Africa Mortality Symposium. I think it's time.
Yeah, sorry, I wanted to try and change the screens and I lost the slides.
Okay, so our next step is just to strengthen the data use culture and move from data collection to data-driven action, including the planned symposium and regular bulletins. And to do any of this, we are looking for funders to sustain this SRA system. We believe that 10 years is required minimum to stabilize the infrastructure and to do other activities. We are looking for funders. Thanks very much.
Thank you. Thank you so much. This was a very great presentation. So we had two very interesting complementary presentations. One from Daniel's presentation, we heard about how to develop a framework for monitoring SRS implementation and also project implementation. And then with the example from Sierra Leone, we saw how data can be used for monitoring public health outcomes and how it can trigger and facilitate coordination among different stakeholders. We have 5 minutes and the floor is open for your questions or comments. You can raise your hands or unmute. Or you can also share your design for M&E framework for your SRS from the 6 countries. If we have someone, I see like we have from Pakistan team, from Mali team, if you want to share your insights, that would also be interesting to hear. Yes, Bola, please go ahead.
Okay, thank you very much. I hope I can be heard.
Yes, we can hear you.
Okay,